My name is Siobhan Reynolds and I'm here with my colleagues Naomi, Chloe, Maureen and Denise for our third QI Talk Time of 2021. So welcome everybody. We're delighted today to focus in on measurement for improvement and assurance, and our topic today is making data count. So today we're going to learn about the power of statistical process control, SPC, as an insurance tool as well as an improvement tool. We're going to introduce you to key techniques to maximise the impact of SPC to drive effective decision making, and learn about free training opportunities and resources to help make data count. We're joined today by Samantha Riley from the NHS, and Samantha is a self-confessed information junkie. Samantha is a proponent of using SPC. She's an author of the excellent Making Data Count guides, which we are familiar with here in Ireland. And more importantly, Samantha says she has a very large collection of sunglasses and a very impressive shoe collection. So we're dying to hear more about that, Samantha. And we're also joined today by Dr. Jennifer Martin, who's a very busy specialist in public health medicine. And her current day job is working here on the National Contact Management Programme here in Ireland. Pre-COVID, Jennifer led the Evidence for Improvement team, and they've been working on a number of support programs for HSE staff to enable them to collect, interpret and contextualize data. So before we hear from Samantha and our panelist Jennifer, we have a number of housekeeping items just to bring to your attention. The dial-in number today is 01526 0058. And the event number is 183-727-7063 hash. And you can use your computer or phone for audio. Some people find the phone is a better option with regard to audio. We'll have our chat box live, and please put in any comments, ideas and questions for our two panelists today. And we'll endeavour to get to them all after the presentations. We aim for this session to be as interactive as possible, and we'll make the slides available afterwards on our website, and we'll also record the webinar and we'll make that available to you all as well. And we'll also have a small survey at the end of the webinar, and we'd be grateful if you could enter in your feedback to help us improve future QI talk times. So without further ado, I'm going to hand you over to our presenter, Samantha, and also to Jennifer. Thanks very much.
Brilliant. I'm hoping that you can hear me okay.
Yeah, great, Samantha. Thank you.
Fabulous. Excellent. So great to be here. I'm going to jump straight into my slides. If you just confirm once you can see them, that would be fabulous.
Yes, Samantha, we can see them. Thanks.
Okay, and I'm just going to put them onto slideshow. Brilliant. So I'm here to talk about making data count. So just by way of quick introduction. So yes, I've got lots of shoes and sunglasses, but I do have a role in the NHS. So I work for the organisation NHS England and Improvement, and I'm really passionate about data. So I've got a really small team, and over the past 3 years, we've been doing a huge amount of work in the NHS, helping people make better use of their data. We started that work working at the most senior level of organisations, so working with trust boards. We've now run 120 board sessions, which is around half of the trusts in England. As a result of a 90-minute training session, I'm going to give you a tiny little snippet of what we do today with boards. Every single board has agreed that they're going to change how they use their data. So we're on a bit of a wave now in terms of change for the better. Over the past year, I should say, we have actually delivered training to around 3,000 people. And I'm going to talk at the end about how you can gain access to the training. So I thought I'd just start by sharing a few different visualizations of information just to kind of get us going. So I'm not wanting you to comment on these particularly. Feel free if you want to, of course. But here are some real examples of data. So here's a beautiful one, isn't it? Maybe a piece of modern art. It is real though, from when I worked in West London many years ago. This is one that I found more recently. We call these graphs spaghetti graphs. We see quite a lot of them, different coloured lines saying a different thing. Not sure how useful spaghetti graphs are. Now, I never like a pie chart. They should never be used. We all know there's a better way, don't we? There's a Pareto chart. We don't want a pie chart. We certainly don't want a pie chart with these kinds of colours. That's just mad, isn't it? That was a Twitter one. Now this one, I quite like the colours, I have to be honest. Nice gentle colours, do like my colours. So we've referred to this one as the donut. Maybe you want to sprinkle some sugar on this one. Again, it's a real example. What on earth are we ever going to do with this in terms of making a decision or doing something? How about this one? Annual trends. Well, I suppose we kind of learned something from this one. We learned that everybody's kind of in the same ballpark, don't we? But again, how on earth could we act when we look at that? But moving on to more sensible examples, why I say they're sensible examples, when I look at the NHS in England, this is what we see people looking at. So I don't know if this is typical of what you see in Ireland as well. So we see lots of RAG reporting, stacks and stacks and stacks of them. So do you see things like this? So I'd be interested. Do you want to type into the chat box? I'm just going to open that up. Is England unusual, or are you also seeing things that look a little bit like this? So I've just got some little examples here. So I'm wondering, is England unusual? Are you different in Ireland? Maybe I'm wasting my time. Maybe you've got this all sorted in Ireland. But this is what we are. Okay, I can see a comment from a couple of people that these are looking quite familiar as well. This one's a particular favourite. Of course, it's not really a favourite, where we've got these arrows as well. So not helpful visualizations of data. So lots of RAG reporting we see. What else do we see? We do see lots of these little arrows. So here we see an arrow that tells us that the number went up this month. And what else do I see? I see a comment that talks about a very small increase. Now, my question to you, is this a useful comment to draw people's attention to, or might it be distracting? I know what I think about this. And here's a little test for you. Again, I don't need you to type this in, but think about it. If we've got two numbers, what do we know about the second number in relation to the first? You don't need to be a maths wizard to know the answer to this, honestly. Think about it. We've got two numbers. The second number is either going to be higher or lower or the same, isn't it? Those are the only options. So I don't know if you ever had this lovely Bruce Forsyth quiz show in Ireland. This was playing your cards right. I used to watch this when I was a child. This was very much the card's going to be higher or lower or the same. Yet in the NHS, we often treat our data in exactly the same way. That's my experience anyway. We also see lots and lots of comments like this. I've used one example, but we fall over ourselves with seeing comments that look like this, talking about tiny changes in the data. So let's look at a little example. So here we've got a RAG table. If you're colourblind, by the way, you won't be able to see the red and the green. So this is a red and green coloured table, and this relates to elective waiting times. We've got a target in England around elective waiting times. Now, when we go and talk to all of these boards, most boards at the start of the training tell us that the RAG table is helpful because it's telling them that they need to focus on a particular subset of things within this report, and they're going to be focused on the red in the main. So let's have a look at a couple of little examples. So here we're looking at general surgery. It's all red with a downward arrow. So do we think that everything's awful and it's getting worse? Quite probably. So let's plot the data as one of these SPC charts that I'm really keen on. So what do we see here? Without even being an SPC expert, we can probably conclude from this graph that actually general surgery has made some fantastic progress. So we've got the target line in the red dotted line, and I should say at this point we've agreed a colour convention in our SPC charts, the blue where we're seeing improvement and orange where we're seeing performance, which is concerning. So what should be the message to general surgery? It should in fact be fantastic improvement work, guys. Well done. You've done incredibly. Look, we can see you're not meeting the target yet, but you're going to get there really soon. We're confident of that. So keep going. Say well done to the team. amazing. We're not going to hit you over the head because you're still failing the target. Let's have a look at rheumatology. So here we can see the same visual in the bag report. So it's all red with a downward arrow. What are we going to see if we plot it as an SPC chart? So let's have a look. Are we going to see the same thing? No, we're seeing a totally different picture here. So here we can see that in fact the performance has been concerning for quite a period of time. So here we need to provide rheumatology with some help. What's going on here? So it's a very different reaction, isn't it? And it would have been really easy to misinterpret those important messages and very different messages from the data in that RAG table. So these are normally the examples that are enough to prove to people that in fact RAG reporting is a really bad way to look at your data. So we're going to jump into a little scenario now, and I am hoping that you're going to be able to use the chat box. Now, this is a scenario that we use with the boards that we work with. And I'm going to simulate a real data set in a healthcare setting, and we're going to be thinking about how people react to trends and patterns in the data. Now, I'm going to pretend that this data relates to the number of serious incidents. Now, I know that's a very complicated area, but for this exercise, we simply want the number of incidents to be reducing. Now, I'm the program director for serious incident reduction, and you're going to have a really exciting opportunity now, because as we go through this scenario, I'm going to give you the opportunity to give me feedback on how well I am doing my job. So you didn't realise that was going to happen today, did you? So let's start. So we had an 8, an 11, 11, a 19, a 14 and a 15. So we've got 6 months of data there. We're going to add in a median line. We've got a run chart. What might a linear trend line look like? I'm sure you can imagine. So we're going to just put one onto the graph here. So here's your first opportunity. If you think I'm doing a good job, type in good. A bad job, type in bad. And if you're not sure yet, I'd like you to type in a question mark. So remember, we want the number of incidents to be reducing. Am I doing a good job, a bad job, or are you not sure? We want those numbers to be getting smaller. Okay, so I can see a bit of a mixture of comments coming in here. So a few people not sure. Seen a couple of bads there. Okay, this is when I decide if I'm ever going to come and visit you in Ireland. So, okay, I'm getting a view here that you probably think I'm not doing the best job at this point. Okay, but a mixture. Okay, that's fair enough. That's normal. That's the kind of reactions that we normally get. So let's have a look and see what happens next. So I got a 9, a 14, a 12 and a 5. So look at that, guys. Look at that. Isn't that amazing? That's the lowest number that we've seen so far. So I'll ask you the same question again. So am I doing a good job, a bad job, or are you still not sure? Some of you might have changed your mind, of course. So type into the chat box. And I'm interested. Now, in England, we never get bonuses in the NHS. I don't know if that's the same in Ireland. I would have thought it's probably the same. But if any of you could give me a bonus, does anybody want to award me a bonus? Because look, that's the lowest number. I've worked really, 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 really hard, really hard. I'm not seeing the word bonus, which is what I want you to type in. So no. Okay, you're not as generous as I thought you were going to be. So I'm going to move us on. So it's clear that there's no bonus going to be forthcoming. So what happened next? We got a 9, a 10, a 14 and a 15. So you were right to not award me that bonus if you might have been considering it. Because look what's happened. We've trebled the number of incidents. We've got a negative trend of 4. So that's not at all good, is that? Now I'm going to add one more data point, and now we've got enough data for an SPC chart. So I'm going to add in those additional lines that we get on an SPC chart. If you don't know what SPC is, I am going to talk to you about this in a moment. But here's your last opportunity. So am I doing a good job? Am I doing a bad job? Are you still not sure about how well I'm doing my job? Follow-on question to you. Does anybody think it's time to send me away? So do I need a new job? You're going to have a conversation with me or give me the sack. Type in boot if you want to boot me out of the organisation. So yeah, here's your last opportunity. I can see a couple of people not terribly impressed with what I've been doing. It doesn't look like I've had much impact, does it? If I've been trying to reduce those incidents, it doesn't look like that's worked. So if you did want to have a conversation with me, we haven't got any data to compare to anybody else, I'm afraid. My job was just to reduce the number of incidents. So I think if you did want to get rid of me at this point, that's probably fair, because it looks like the data's just been bouncing up and down. It doesn't look like those incidents have been reducing at all. But Siobhan's a really lovely lady, because I've met her a couple of times now, and Siobhan's going to keep me on. She's going to give me one more chance in this job, and that's brilliant, because I've got an amazing idea now, Siobhan, and I'm going to implement it right now, and I'm expecting an immediate impact. I'd like you all to type yes in the chat box once you're confident this idea has been successful. We're going to roll it out to the whole country. We're going to go big with this one. So I'm going to implement it right now. So there we go. So the first month, there we got 7. So I reckon that's probably a little bit early, because you weren't terribly excited about the 5. So now we've got 2 months of success. Is that still a little bit early, maybe? 3 months of success. We could be here for another hour. You don't know how many slides I've got that look like this. 4 months. It's looking quite hopeful now, isn't it? Now 5 months. Look, my idea is being incredibly successful. I can't see anybody looking happy in the chat box yet, though. 6 months of success. I'm getting ready for the party now. 7 months of success. God, you're a difficult lot. Okay, here we go. So I can see some comments suggesting that yes, now we can maybe arrange to have that party. So fabulous. And you can see that those dots have changed to a slightly different shade of blue. So here becomes the really exciting moment. That's the big reveal moment. So I told you I was using a real data set, but I didn't tell you what the data set was. So what was the data that we were looking at? So it related to Beatles' #1 hit singles. So they were, of course, a pretty famous band in their day. What were we looking at to start with? We were looking at the number of characters in the song titles of consecutive #1 hits. So when I wanted the bonus, that was help, ! And then we had that negative trend of 4, didn't we? Starting at Day Tripper. Now, why do we run this scenario with boards? You know, is it a bit of a silly thing to do? Well, we do it to show people that even in a totally random data set, we have high points. We had a 19, we had that low point of 5. We have patterns in data, which can just be random data. And clearly we've got a really good example here. Now, the problem is that sometimes we try and apply significance to some of those patterns or points that are high or low. And the problem is that then we can waste a lot of time and trouble. Now, when I implemented the improvement idea, I cheated and I changed what I was plotting. So I was plotting constants only. Of course, the great thing about the SPC chart is it knew that a change had occurred. So of course, that is a brilliant thing about SPC. It tells us whether a change that we've implemented has resulted in improvement. And of course, that's been the kind of traditional context in which we've used SPC in the NHS. And I'm going to come on a little bit later in terms of how we've used SPC as a slightly different approach in England. Now, when we overreact to data, there is a big problem. And I'm going to introduce you to a word now, which is probably a new word. So, have you heard of spuddling? Probably not. So it is a real word, it's several hundred years old. And what's the definition? The definition is to make a lot of fuss about trivial things as if they were important. And I would suggest to you that in the NHS, we have a great tendency to spuddle with our data and overreact to a data point. So spuddling is a bad thing. We don't want the big fuss and drama of spuddling, overreacting to a data point that might have just moved randomly. Now, boards really liked this word, spuddling. It really kind of chimed with them. People took a photograph of the slide, and what people asked us for was, could we create some cards for them to use in their meetings? So here we've got Alistair, he's an anaesthetist. He was the owner of the first set of spuddling cards. So you will notice they don't say you are spuddling, it's asking the question. So are you spuddling? He raises the yellow card if he's in a meeting where he suspects that somebody's overreacting to a data point. And if they do it again, he raises that red card of a kind of second warning. You can see the link with football here, can't you? Now, it sounds like a silly thing, but it's really started to drive some behaviour change because it's kind of a gentle way of challenging poor behaviour. So it's really starting to have an impact. So why are we doing all of this work? Me and my tiny team, there's 4 of us, focusing on use of SPC. Is it a new faddy thing? Well, many of you will know it's not new. It's been around for over 100 years. Started in industry, but it's highly applicable to healthcare. So these are the 2 papers that we encourage people to have a read of, which talk about the dangers of RAG reporting. So what's the anatomy of a chart? I'm sure that many of you are familiar with these, so I'm just going to skim over it. So they're simple charts, of course, it's time series data. We've got the 3 reference lines, we've got the mean or the average, and then we've got the additional lines called process or control limits, set on a very particular calculation. Not to go into technical stuff here, but just to say the most common error that we see in England is people using the incorrect calculation for the process limits. It needs to be 3 sigma, not 3 standard deviation. They are different things. But what's the important thing for us to remember about the process limits? Around 99% of data points are going to fall between those dotted lines, and that is, of course, very important to remember. We know that there's a minimum number of points that we need to create a robust chart. We've looked at all of the evidence. There isn't precise agreement. So we've been pragmatic and said if you've got 15 points, you've got enough. So we have SPC rules, and if a rule is triggered, it tells us there's an unusual pattern in the data that's unlikely to have occurred randomly. Now, these are the 4 that we are recommending for use in healthcare. I'm not going to go through them all. I'm sure that you're familiar with them, but I am going to remind you of our colour convention. So orange, all you need to remember is if you see an orange dot or series of dots, and that's telling you there's an unusual pattern in the data that is of concerning data. So orange is for concern. And where we see blue, that means that we're seeing improvement. If we're just seeing grey dots, it's just that common cause or expected variation like we saw in the first part of that beetle scenario. So if we see that special cause variation, if we see a rule triggered, we do of course need to go and find out what has caused it, because something is going on with your data. But I said a moment ago that in England, we focused SPC in a different way. Now, at the start of our training with boards, we used to use the term measurement for improvement, and that was a kind of familiar term that we used. You might be familiar with the research from many years ago where there were terms measurement for improvement, judgment, and research. Now, we stopped using the term measurement for improvement because what we found was the board members said, yes, we know about SPC. That's what we use when we've got an improvement project. But we've got lots of targets, as I'm sure you do in Ireland. I know you do, in fact, from having visited. So we're interested in assurance. And the job for the tool for the job there is the RAG report. It's not SPC. What we focus our training on is the benefits of SPC as a tool for assurance. So if we think about this example here, we've got a target. So we need to achieve this target of 40 or greater. And here we've got an SPC chart just with common cause variation. So what do we learn from looking at this chart about the likelihood of achieving the target? Well, because of course we now know that the data falls between the grey dotted lines, we know that this is not a capable system. The only way we're going to achieve that target is a fluke occurrence. So we need to redesign the system if we want to be achieving the target. In this example, we did see the target line is very close to the mean. What's this going to look like in a RAG table? It's going to look something like green, red, red, green, red, red, green, etc., etc., etc. That is, of course, when I'm worried about the spuddling behaviour, particularly when we go into the red, there might be a big panic. I'd want to understand, are there things happening here when we achieve the target? Could we learn from them? That might be the case, it might not be the case. We might well have to do the redesign work in this instance as well. And of course, if we're going to do redesign work, we're going to think about what we're measuring, and we're going to hopefully end up with a beautiful SPC chart. This is my favourite one ever. This is length of stay for frail elderly patients, and you can see it's an annotated chart where we move from having wide process limits at the start to actually very tight process limits towards the end of that graph. So I still don't see enough graphs that look like this, to have to be honest. If you've got any lovely ones, hey, I could start using one of yours in my training. Now, what have we learnt about maximising the impact of SPC? We've learnt some important things over the past few years. The first thing is undoubtedly the importance of highlighting that special cause variation. Where we've seen people using SPC and the special cause hasn't been highlighted, which in the main has been the case, I don't think it's been that impactful, because people have had to remember the dots, count the dots, remember the rules, etc. So remember, people with our teaching just need to remember the colour convention: orange for concern, blue for improvement. How do we avoid having hundreds of SPC charts? Well, here's our solution to that. So I think we're interested in two things when we're looking at data. So we're interested in, is the performance getting worse? Is it getting better, or is it staying the same? So here we've got the variation icon that tells us that. So an orange icon concerning, blue icon improvement, and grey that's just that common cause variation. And then we've got assurance icons that we use if we have got targets. So the blue P says that we're going to consistently hit the target, past the target. That's of course looking at where the target line lies in relation to the process limits. The orange F, we're always going to fail, and then we've got that flip-flop situation. And the last thing just to mention is that we do of course need those words to be in line with what the chart is telling us, and we are finding that people are struggling with that a little bit. Even when they've got beautiful charts, they are still writing about the fact that things went down by 0.025%, etc. Now, when we run our board training sessions, we do use real examples. So we tailor every single training session using local data. So I've just got a couple of little examples for you. So cancer's 62-day performance, we've got a target with this. You can see they were using a RAG table. Now, I had a little look at the words. So what did I learn? I read about pressures continuing in the first 2 months, a recovered position in March. I looked back at some previous reports, and what did I read? Pressures continuing, a good recovery, sustainment being difficult, and August showing improvement. So what does my SPC chart look like? So here's what it looks like. I've done something you might think is a bit odd. I've coloured the dots here dependent on whether the target's being achieved or not. The target is the red dotted line. So what am I worried about here? You already know, just 20 minutes in, you know that I'm worried about spuddling behaviour. I'm worried that when people go into the red, they are going to spuddle. But let's take away those artificial colours. What do we see here? We've just got those grey dots of common cause variation. Now I'm just going to overlay when those comments were made in the narrative supporting their RAG table. So pressures, recovery, difficult times and improvement. Whereas in fact, we already know what's going on here. We've got that common cause variation. Nothing is changing. We have, of course, got limits that are pretty wide. So we would want to be understanding the width of those limits and doing something about it, rather than just tampering with one data point, making kind of knee-jerk reaction, because we're going to hit and miss that target randomly. Another cancer example from another trust. So here we've got another horrible graph. So we've got a bar chart, we've got spaghetti. I told you earlier, I don't like spaghetti at all. And what's the narrative tell us? We've got a further decline from last month, a doubling of treatments in year, most treatments in December, and then I read about a recovery plan. So what is my SPC chart going to reveal? So this is what it reveals. So you don't need to be an SPC expert to know what you're seeing here. We've got those orange dots. They've been ongoing for 13 months. Those 13 months of concerning performance. People knew things weren't good, but they didn't realise they were this bad. It's been going on for that length of time. Then we can look at the target line and the process limits. Target line's pretty close, isn't it, to that upper process limit? So it's unlikely we're going to achieve the target. And we achieved it a long time ago. We last achieved it a long time ago. Then I wonder, if I was on this board, when would I have seen that was a concerning pattern? And so they would have noticed it at least 6 months earlier in their November board meeting. What were they looking at then? They were looking at the same horrible chart with less data. But here we get to the important part, really. What did I read in the narrative? I read about an improvement in performance. That's because it was better slightly this month than last month. And I read about optimism to deliver by the end of the year. Now, you've seen that did not happen. A non-exec director said at the end of the board session, she remembered this board meeting. It was her first board meeting, and she felt reassured by the optimism. So I'm optimistic, but clearly optimism is not enough. So what resources are available? Hopefully I've whetted your appetite. We have 2 interactive PDFs, and here's the web link. I think we're going to see those going to the chat box. Just to say, we also do have some little hard copy mini guides, which I'm happy to send if people are interested, a box over. We're just getting some new ones printed, so I'm happy to share a box of those. I do have spuddling cards that I can share as well. We do have a range of other resources. So we have a range of free Excel-based SPC tools. So here we've got the single XMR tool. I should say that we do only teach XMR, and I'm happy to maybe talk about that more as a result of a question. We're only teaching XMR charts. So here we can see the Excel tool. I did dry January, and bizarrely for me, I've kept going since then, which is very odd. So I haven't had a drink since New Year's Eve. And here's my overnight heart rate. So I know that they say that your heart rate overnight reduces if you don't drink. Well, here's the absolute proof. So that's a little bit of fun. We've also got a tool that creates a 12 chart SBC dashboard for you. And also we've got a 50 chart tool if anybody's interested. I've talked a lot about boards. It's not just about boards, of course it's not. So here's an example. I read about an organisation moving away from complex narrative, and I met Ree on Twitter. So Ree had led lots of work on reducing falls, and they'd done all of this work, but she didn't know if it had made a difference. So here she is, she's used our SPC tool. She's got those blue dots of improvement, which is why she's very happy. So we do deliver training ourselves. So we once a month deliver these 5 steps of training. So step 1 is basically what we deliver to boards. That's an introductory session. They're all an hour. Then step 2, we cover all of our SPC tools. Step 3, we're focusing on writing narrative. That's a very popular session. And then step 4, we go into a bit more depth on SPC and provide some advice to people if they want to convert their colleagues. Step 5, we haven't delivered yet. That's going to be on comparison and benchmarking. We've got a futures site, which any of you can join if you email the Workspace Manager. We've now got over 1,000 people on this platform. We've got all of our training information, recordings, an event calendar, useful research papers, and there's a discussion forum there. So we are actually getting people to ask questions, and other people are answering them and have debate, which is fabulous. So my passing thought before I hand over to Jennifer is, if we adopted SPC as a more standard approach, yes, it's not the right approach for all of our data, but it is for much of our data. What would we be? I would suggest that we would be less headless chicken. And if we were less headless chicken, what could we focus on? We could focus all of our valuable time, effort, resource, energy, etc. onto our patients. So that's all from me, a little intro to making data count.
Thanks so much, Samantha, for that, and thanks for sharing your excellent resources. We've looked at them previously, and they really are excellent. So I know Naomi's put in some of the links into the chat box for people to get access to those resources. So maybe I'll just hand over, before we take any questions, if people could have a think about any questions for Samantha, I'll hand over here to Jennifer, who's just going to explain, I suppose, what's information with regard to the Irish, I suppose, side of things, and the work that Jennifer and her team have been doing. So thanks, Jennifer.
Hi, everybody. Thanks a million, Siobhan. Well, following the tour de force from Sam, and yes, we'll definitely take a box of data count. I love the hard copy, and for anyone who hasn't seen it, they're just it's the nicest, easy, accessible guide, because I know one of the things about measurement, and I totally agree with Sam's view on, I think SPC is really good as measurement for improvement and measurement for assurance. But one of the things that goes with measurement, I think, is quite a lot of anxiety, and it can seem quite overwhelming and difficult. And Sam, you do a great job at, making it a bit easier. And the guide is particularly good at that. So what I'm going to do is, obviously Sam has really, for anybody who wasn't already convinced, which is probably not that many people on this call, of the benefits of looking at information over time and using SPC and kind of some of the how it works. What I just thought I would do for Sam, as much as anybody, is just do little showcases, some of the work that we've been doing in Ireland nationally, and then I just have a few examples of what other people around the country are doing, because we're certainly very much on that journey in Ireland, and we're really very much on that journey at the very top of the health service, which is great, with our executive management team and our HSE board really starting to use these methods. So I have some slides which I hope I will share, and I hope I will. Now, why am I not seeing the share on this? Oh, I am now, sorry, apologies. Give me 1 second. So tell me, see my slides.
Something's happening.
No? Siobhan, you're on mute. Not seeing it, no?
Something's happening there.
Yeah, sorry.
It seems a bit slow. Do you want me to try and see if I can pull them up, Jennifer? Would that help? And if you want to do some talking?
If it works for me better, because I'm
Yes.
going to
you're gonna share.
fly through them. I think it might be hard to keep up, but if it's not happening in the next moment, we'll have to do that. Very annoying. It's on now. Is that no? Feel is
No.
it coming up yet?
No.
No. Therefore, and if something happens.
So are you okay?
So while you're pulling them up, so and then just to say, I think WebEx is not my friend. Okay, so Chloe's sharing. Okay, so anyway, for those of you, I know Jennifer Martin, as Siobhan said, and yes, I'm working in the National Evidence for Improvement lead, though I suppose 95% of my time at the moment is on the management program. And the team for improvement, and most of the work that you're going to see here nationally is done by Grania, Emma and Nicola, and we also have Gemma and Dunira.
I think we're losing Jennifer there, are we? Yeah, we are. Yeah, we've lost her, I think, I'm afraid. We'll hopefully try and get her back. Can I just, maybe while we're waiting to see if we can get Jennifer back in, can I just check if anybody has any questions for Samantha? And if you wanted to put them in the chat box, that'd be great.
I saw a little, it's a tongue-in-cheek question from Philip about, does a red card eject people from the meeting? Well, that's a good question, Philip. I haven't heard any stories of that happening quite yet. Not to say it hasn't happened. So, you know, if I send you a set of cards, then please feel free to tell me if you have that experience.
Great. Have we got you back, Jennifer?
Okay, so I've got another question I can see from Philip.
Yes.
How widely are SPC charts used in the NHS now? I'd say when we started this work, not very much at all. So we did see SPC used only in the area of quality, really. But apart from that, and even in the areas of quality, still we often see quite a lot of lag reporting. But actually all of those boards that we've worked with have now changed their reporting. So if anybody follows me on Twitter, I often do tweet examples of what good reporting looks like. So we've got a really good kind of wave of change happening in the NHS. And of course, a lot of organisations are starting at the board and cascading it down to their organisations. And in a sense, I know that COVID has been absolutely awful, but in a sense, it's made us do something which we just wouldn't have done. We were doing face-to-face training before, which of course is great, but quite limited. We just wouldn't have been able to have the reach that we've got now, where people can kind of jump on at lunchtime to one of our training sessions. So I would say it's much more popular now. There's been some research done at Warwick University that's been submitted for publication, hopefully in BMJ Quality and Safety soon, where they did an independent assessment of use of SPC. And I think that they've seen that there's been quite a significant pickup over the past few years, which is great.
Great, Samantha. And can I just ask a question in relation to your board work? Did you have to train particular individuals who support boards with regards to the SPC charts? So who do you support that work with boards? Are there particular individuals that you work with?
Yeah, so it's a good question. So it's very limited what we can provide in terms of support, and my team primarily supports those trusts and systems that are the most challenged, and they do get a bit more kind of hand holding. What we encourage is that we get the performance head and the information lead in the board sessions. They hear the same message at the same time. Different trusts in England would use different types of systems. They might use Power BI or Tableau or Excel. They might be using different things. We're not experts in all of those areas. So at the end of last year, we established an analyst network. We've now got over 300 analysts on the invite list. If there are any analysts on this session, feel free to send me an email. Very happy to add you to the list. The idea of that network is that we can kind of share stuff that's happening at a national level, but that we get people to actually share their knowledge and expertise at a local level. So we've had sessions run on making data count in Power BI. We've had trusts share what they've done. They've shared all of their code. We've had a session on Tableau. And for anybody really technical, we've now got the R community building some stuff in R for making data count. So we haven't, in answer to your question, it's limited what we can provide in terms of support ourselves, but we try to provide the kind of infrastructure there to help people out, and we've got SQL code that people can use. And for those most challenged trusts, we will of course provide them with more support, but because we've got our monthly virtual training, we're just really directing everybody to jump onto that training.
I think we've got Jennifer back on now. Jennifer, could just checking in with you. Jennifer, are you on there? No. No, I'm afraid not. We've seemed to have lost her again. Samantha, can I just ask you a question with regard to maybe services that don't maybe necessarily have a lot of support? They might be small services and they mightn't have IT or people who are interested in data. And how would they go about starting, I suppose, on this journey for small services?
Yeah. Okay, so this is going to be an advert for what we do here. So again, I say start with our training. So sign up to a step 1 training session. Bearing in mind, of course, that we're probably teaching slightly different things here to what you might be teaching in Ireland. I'm conscious of that, so just bearing that in mind. I, for instance, saw that Jennifer put in the chat that in Ireland you tend to use 8 points for an SPC run. We use 7, or increasingly, actually, if I was seeing a concerning pattern in the data, I'd be wanting to use 6. If I think about it through the eyes of somebody needing to make a decision about some performance that might be concerning, if I was using monthly data, I'd probably be using 6. Anyway, so putting that aside, so we do teach slightly different things. So if I was advising somebody that maybe was working on a ward or maybe was a physio or doing something like that, why not sign up to our next step 1 training session? It's an hour, or you can go and watch one of the recorded sessions. But I think it's more fun to join a real one. And we do, of course, have all of these Excel tools that I've mentioned. So then you might want to commit to step 2, or if you don't want to spend an hour, you could just download the tools and you could just basically just key in your data. And I think that's a really, really good starting point just to get started. I do know it can be scary for people. We've just tried to focus on making it as absolutely simple as possible. And those tools were developed with frontline staff in mind, because of course, I'm sure you're the same, that analytical resource is quite a scant resource, isn't it? And we've got all of our analysts mainly sending national returns up to tell us how things are going, rather than focusing on supporting teams. So that would be my advice.
Great, thanks very much for that, Samantha. Any other questions for Samantha? I'm just going to scroll through just to make sure. Is there anything else in the audience maybe for Samantha? No? Any other questions on what's been presented today?
Oh, stunned silence.
Yes, exactly. Exactly. And can I ask you, Samantha, with regard to challenges, did you find maybe there was some challenges with regard to bringing in a new way of displaying data? What kind of challenges did you come across when you were working with the boards or with various executive teams?
Yes, and I can see another couple of questions coming, but yes, I'll take that one. So in terms of challenges, the honest truth, and this is totally honest, is we haven't really had a challenge in getting people to agree to change. And I think the key to that has been keeping the sessions really kind of light and not heavy sessions. There's definitely something about the style of presenting. We've got our own paper, hopefully going to be published in BMJ Leader very soon. I sent in the final paper on Sunday. So we've done it in a very kind of accessible way, the training, but without any doubt at all, we know this from independent evaluation interviews, the fact that we've tailored sessions using local data has been absolutely key. So what we've been showing people is, I mean, it's a bit of a delicate line to tread, as I'm sure you can imagine. We're basically going into all of these boards and telling them what you've been using for the past months, if not years, has led you to making poor decisions, which is not good at all. But we've shown them a better way, and we've shown them that in fact there are very different messages from the data if you use SPC, and we've talked about how we can equip their analysts with how to do it. So we haven't had challenges with our trusts. What I have had challenges with is getting my own organisation to actually make those changes as well. And I should say the organisation I work for is a regulator. So we're the ones that have the conversations with organisations about performance. However, I've got one region now which has agreed to change all of their performance reporting to SPC. So I think that there is light at the end of the tunnel on that one. But, you know, it's been surprising. We just haven't had the number of challenges that you might have foreseen. So I can see a question about XMR.
Yes.
Yeah,
Yes.
so I'm going to cover that one because I think that's a useful one. So we really wanted to keep this as simple as possible. And many people, of course, have written about SPC, including somebody called Donald Wheeler. So Donald's in his 70s now, in his 20s, in his 70s, and he still does training on SPC, and he's written lots of books. And Don Wheeler's approach is that XMR is good enough for pretty much all of your data. So because we wanted to keep it simple, and because we were aware of the evidence around the fact that people get confused about different SPC charts and therefore get put off of using it, what we decided to do is follow the Donald Wheeler approach. Now, there are lots of benefits around the XMR charts. The data does not need to be distributed in a particular way, and the multitude of other charts that are out there, the data does need to be distributed in a very particular way. So that's a big benefit of using XMR. And I can tweet some links later if people are interested, or we've got papers on our sharing platform that I mentioned earlier that talk about that. Now, there's also some research that's been done that suggests that XMR is the best tool of choice for healthcare, because we can be not very often very certain about the distribution of the data. Now, I've got a statistician in my team called Karen, and I nagged Karen for quite a long time. And I said, Karen, we've got all of these other charts. And our sense was, of course, we're going to get more refined messages from the data if we do use the P chart, etc., etc. So Karen ran some data. So I think she did the P chart. She's definitely done the C chart. Can't remember. She's done another couple. And you know what she found as a result of using the XMR chart compared to those different types of charts? The messages from the data were virtually the same, if not the same, if not the same. So that strengthened our views in terms of our choice of using XMR. Now, clearly, if you've got rare events, you do need to use a different type of charts. We absolutely agree with that. But we've almost strengthened our case, I would suggest, by doing that comparison. So we're sticking with XMR chart for now for those reasons. I think it's a good question. I think some other people have now started to question, actually, people do get confused if they see the charts with the process limits moving all over the place. You know, does that give us more refinement? So this is a genuine question to people on this session. If you've got examples where you get different messages dependent on the chart that you use, please do send them to us, because that's exactly what we want to be finding. But that has just been our findings so far.
Great, thanks, Samantha. Jennifer, I see you're back in there. Can we hear you okay? No sound. Okay, I'll just look to see whether any other questions. Can you tell us a little bit more, Samantha, about colour coding?
So yes, so we've agreed that colour convention of orange for concern and blue for improvement. Now, one of the reasons that we chose those colours is apparently they're two of the most impactful colours. If you see lots of advertising, it's often orange and blue. But the big benefit is if you're colourblind, you can differentiate between those colours as well. So people that are colourblind can see the orange and the blue on the SPC charts, which is fabulous. So all of the tools that we've got, all of the code that's produced, all of our trusts that have adopted the Making Data Count approach, they will be using those two colours to trigger, when those rules are triggered, whichever SPC rule is triggered, they will use that colour coding. So orange for concern, blue for improvement, grey just for that common cause variation. So it's as simple as that. So it's just highlighting the special cause variation, using that colour convention. So it really means it's easy, isn't it, for people to remember orange is bad, blue is good. That's all people need to remember. They don't need to remember the rules. So that's as simple as it gets. And the icons, similarly, everything that we do, the icons can be automatically produced. And we've got some image files for those icons that sit on our future sharing platform.
Great, Samantha. Thanks
I
very
give one
much
more go?
for that. Yes, we can hear you loud and clear,
yay.
Jennifer.
Thanks. Well, we got the questions done before. I'm going to, if Chloe just wants to put up the slides again, just to do a quick whistle stop, literally just show you a few vignettes of what we have in Ireland. And really what I wanted to say, I think, which is interesting is, you know, one of the things around SPCs about a kind of a stable system and everything, and we're not in that in COVID. So Chloe, if you want to just kind of flick through the next few slides, because we're essentially out of time. But so from the start of the pandemic, looking at this one, we started looking straight away at data over time, and the HSE executive management team were used to this because of work we had done with them. And so we look at hospital admissions, and then if you want to move on, we look at deaths, we look at ICU, and we look at the number of cases. So, you know, we look at it just, and I think it was Don Burrick who said, if you do anything, just look at it over time. So if you do nothing else, like in this chart, just plot it over time, you're kind of 80% of the way there. If you have a bit more data, put your median in it and have a run chart. And if you have enough and you have the skills, an SPC is definitely the best. But as Sam is saying, like, not to be put off, anything over time is good. But so this is kind of the simple work we've been doing. And then I just want to, if you want to move on again, we can look at something a little bit more and move on again. We'll skip that one. A little more exciting. Actually, I'll just talk to this one at the spuddling that Sam talks about. We, as everybody knows, amazing political interest in everything about COVID and the counties, and which county's up and which county has more close contacts and which counties' rates are higher. And we had this thing about our northern counties on the border with Northern Ireland. and their rates were high, and what do we have to do? And our colleagues in the Department of Public Health in the Northeast really found a funnel plot, which is a type of SPC, but only has one rule, which is if you're outside the lines, found it really helpful because Cavan was the county with the highest rate. But what you could see from the SPC is that, in fact, it was within the normal expected variation. And they were able to use that to say, really, to our politicians, let's not overreact to what we're seeing here. Dublin, not surprisingly, actually did have a higher rate. So if you want to move on, that's just using our basic methodology. But Grania with Philip have been doing some really interesting work with Lloyd Provost and Rocco Perla, who are kind of really big experts in the SPC world around how to use SPCs in an epidemic or a pandemic as we're in now, because they're not designed to adjust well for this kind of expected massive variation or waves, which we know happen in pandemics. So Rocco Perla designed an SPC chart, which really is two SPC charts, and it accounts for the different waves. So what we know happens is we have like low and stable pre-growth, then we have this massive surge and it plateaus, descends, and then becomes stable again. And there are two things that any SPC chart, as we know, we want to do is to identify the signals really quickly and not overreact to when there isn't actually a signal. So this is just kind of showing you the thinking behind it. And then if you go on, we'll see the slides of how this has been applied to our Irish data. This is a bit busy, I won't go into it, but people will know these are the waves we've seen. The first wave, the massive lockdown, but actually small wave in March, April. Then we had a wave earlier than expected in September, and that stabilized again. And then we had the massive surge around New Year's Eve, and that has gone, has plateaued and is on descent now. But what I think is interesting, right now we can see some signals which are helpful. So if we move on to the next slides, what we can see is, so this is again, so we're using the these modeled SPC charts to deal with these different waves. And actually, sorry to say, we use, totally like Sam, we use colors to signal things, but we don't use it in quite the same way. So in our normal SPC charts, we use pink just to flag something has changed, but we're not actually putting a judgment on whether that's good or bad, because and Eilish, I know from Temple Street's on, one of the things we learned in that project was sometimes, you know, if we had an increase in adverse events, it was because of the attention to them, there was an increase in reporting. And we didn't want to flag that that was a bad thing, because actually we did want the report, even though, you know, the number of adverse events in reality is not wrong. Anyway, in these pandemic charts, they're a little bit different in that we're signaling a change in the phase. So what we see here is everybody knows the cases went way down, but we can actually see from as early as the 9th of March that we had moved from the descent phase to stabilizing again. So really we don't, and unless something changes now, we don't expect that we're going to keep on that downward trajectory. What we're of course worried about is that every other phase a bit keeps going for a period of time, and then it will go to a phase of rapid increase again, so that we're watching carefully. And so if we look at the next one, these were the overall cases. And then the next slide, I think we'll see the hospitalizations, which show the same pattern. And then onto this one, which is ICU admissions. This is a more traditional SPC chart. So this shows a different pattern. So there was a period of stability in February, and then a signal of a further improvement. Fewer ICU admissions obviously is better. So we saw, even though the cases in the hospital admissions had plateaued, we were seeing fewer sick, very sick people. And if you look at the next one in terms of death, it matches the pattern that we see in the ICU, in that it has been a further signal of improvement. So look, I think that's just some exciting, really quite, high-tech work that the team have been doing. I think we'll skip the rest of them, but if people want to look at the slides, really the other slides what I wanted to share was just to say that, there are lots of people and lots of people on this call, I'm sure, involved in looking at information over time and using SPC to inform this. And we have, even in our national performance report, which used to be entirely RAG, it is still RAG, but it also has the trends over time, which is in a time series, which is really helpful. And then in some parts of that, we're doing, the SPCs for example, the HCAIs. And then different hospitals are publishing, and that's another great, I think, a change in Ireland. We always look to the NHS on this one. They've always been so transparent. That's a really important tenet as well. And it's great to see different hospital groups now publishing a lot of their information, and that's really welcome. So great to everybody who's done it, and keep up the good work. And apologies, it's been such a disaster technically. So back over to you, Siobhan.
Thanks, Jennifer. And I know you've shared some examples where you've worked with our own HSE board with regard to the reports that they look at too. So there's lots of examples here in Ireland. Samantha, anything? I'll just leave it with you. Is there anything? I know you've shared a lot of links, and so you've been so generous and kind, and you've shared a lot of links with the group here. Is there anything else you just want to share with our audience today?
I don't think so. Just thanks for having me. I put it in the chat box. Hope to see some of you at future session. My parting thought is, please stop the spuddling. Do what you can to stop the spuddling.
Well, thanks so much, Samantha, for that, and for Jennifer. Thanks for sharing with us other work that you're doing. So it's great, great work. So just to finish up, I just wanted to let you all know that will be a survey popping up at the end. So if you could give us our feedback on today's session, it would be great, and we can share it with the team. And as I said, we'll also be sharing the recording and the slides on our website. And our next QI talk time will be on communicating in a virtual world, which is very topical, on the 20th of April. And we have Professor Peter Gillen and Winnie Ryan who are going to participate on that. And then the 4th of May, we have Learning from COVID Through Stories. And we'll have members of the National QI team and UCD presenting that. And then also on the 18th of May, we have a whole system approach to QI with Dr. Amer Shah. So we have 3 more talk time sessions to look forward to. And thanks very much to everybody for attending today and for participating in the chat box. And thanks for all your questions and comments. And we'll see you soon. So thanks very much. Bye. Bye.